Dear audience, let me introduce my PhD thesis, which is the impact of triglyceride level on the risk and outcome of different diseases. My name is Luca Havelda, and I'm working as a clinical dietitian at the Institute of Pancreatic Diseases. My vision is to contribute to the prevention of diseases in association with hypertriglyceridemia, and therefore my mission is to provide evidence-based and valuable data in this process. To reach my mission, I have 3 specific goals, which I will introduce during my presentation. The first one is a systematic review and a meta-analysis, and it's investigating the different triglyceride effect on the development of diabetes mellitus. As we all experience, the prevalence of type 2 diabetes mellitus more than doubled in the last 20 years, and based on the literature, more than 90% of these cases are preventable among men if the risk factors are eliminated in time. Hypertriglyceridemia can be a potential but modifiable risk factor of diabetes mellitus, and although the association between these 2 diseases is highly investigated, whether there is a dose dependency is still not clear. Based on the guideline, triglyceride level fell into 3 main categories. This is the normal, the borderline, and the high. The prevalence of hypertriglyceridemia is also quite high. It can affect almost 1/3 of the population. Therefore, our aim was to investigate the dose-dependent effect of hypertriglyceridemia on the development of diabetes mellitus. Our question was, does hypertriglyceridemia dose-dependently contribute to the development of diabetes mellitus? We investigated adult population with different triglyceride level, and our outcome of interest was the development of diabetes mellitus. According to our hypothesis, hypertriglyceridemia is a dose-dependent risk factor of diabetes mellitus. We used the following 3 domains in 3 main databases during our systematic search, and after the careful selection process, we included 145 studies into our meta-analysis. Let me show you my results. Here we investigate in the hazard ratios of incidence diabetes mellitus with different baseline triglyceride levels. The comparative group was always those who did not have hypertriglyceridemia. That means that the triglyceride level was below 1.7 millimole per liter. In the first case, we investigated those who had hypertriglyceridemia, so they have a triglyceride level higher than 1.7 millimole per liter. In this case, the pooled hazard ratio was 1.73, which means that there was a significantly higher chance of developing diabetes mellitus during the follow-up period for those who had hypertriglyceridemia at the baseline. But we were curious about the dose dependency, so we have investigated it further with different cutoff values. In case of borderline high triglyceride level, the patient has 1.42 pooled hazard ratio, and in case of the high triglyceride level, 1.84 pooled hazard ratio for the development of diabetes mellitus, which suggests us that it can be a dose-dependent risk factor of diabetes mellitus. We also investigated the mean differences between those who developed diabetes mellitus during the follow-up period compared with those who did not develop, and we find that those who had diabetes mellitus during the follow-up period had almost half millimole per liter higher triglyceride level during baseline. And we thought that maybe we should include more triglyceride-related indexes into our study. And here I would like to show you the hypertriglyceridemia base phenotype. In this case, we divided the population into 4 categories. The first one is always the comparator. These are those who have normal triglyceride level and normal waist circumference. In the first group, you can see those who have elevated triglyceride level but normal waist circumference. In the second group, you can see those who had normal triglyceride level but elevated waist circumference, and in the last group you can see those where both factors were elevated. And as you can see, we reached the highest hazard ratio in both sex groups in case of when the both factors were elevated. Here the pooled hazard ratio was above 3.5 in each sex groups. But it's important to mention that we only reach statistical significance in that case when the patient has normal triglyceride level but elevated waist circumference. We suggest us that elevated waist circumference may even have a more important role in the development of diabetes mellitus than hypertriglyceridemia. We also investigated other factors, and what we experienced that those who belong to the highest quartile to their population had a significantly higher chance of developing diabetes mellitus during the follow-up period than those who belong to the lowest quartile of that group based on the factor. Our strength is the transparent methodology, the large patient numbers, and that we were able to analyze different triglyceride-related factors as well. And our limitation is the heterogeneity, the differences in the definitions and the cutoff values, and that we have included retrospective studies as well. As a conclusion, we can say that hypertriglyceridemia may be a dose-dependent risk factor of diabetes mellitus, and that elevated waist circumference may even have a more important role in this development. Its implication for practice is that to be able to schedule the most optimal follow-up visit for patients according to the predictive risk of diabetes mellitus, and to be able to educate on this prevention. Its implication for clinical research is to find the most effective lifestyle strategies to reduce triglyceride level and to investigate the dose dependency with other cutoff values. Currently, we have submitted it to Diabetes Research and Clinical Practice, and we are waiting for their response. My second topic is also investigating the effect of different triglyceride level, but on the outcome of COVID-19 disease, and it is a register analysis. From 2019, COVID affected millions of people, and its outcome was influenced by many factors, which should be identified to be able to interfere as soon as possible, or even do early intervention when needed. As I already mentioned, the prevalence of hypertriglyceridemia is quite high, and based on the literature, it was associated with inpatient mortality. However, the association between the different triglyceride level and the dose dependency is still not clear. Therefore, our aim was to investigate the dose-dependent effect of hypertriglyceridemia on the outcome of COVID-19 disease. We investigated adult patients with diagnosed COVID infection with different triglyceride level, and their outcome of interest was mortality, intensive care unit admission, length of hospital stay severity, and need for mechanical ventilation. According to our hypothesis, hypertriglyceridemia is associated with worsened outcome of COVID-19 dose-dependently. For this analysis, we are using the coronavirus registry created by Catalog Study Group. And currently we are writing the statistical analysis plan. And just to show you some results, here you can see that the registry consisted of more than 1,000 COVID-positive adult cases, but we were only able to analyze more than 500 cases because this is the population that had triglyceride level measurement during the first 4 days of hospital admission. And as you can see, the mortality and severity rate is quite similar, therefore we can say that it is representative to the whole cohort. And as a preliminary analysis, here you can see that the mortality rate and the more severe disease course, so the severe and critical cases ratio was higher among those who had higher triglyceride level. My third project is comparing the body composition in different acute pancreatitic disease stages, and it is a cohort analysis. The incidence of acute pancreatitis have increased in the last decades, and currently its disease continuum is acute pancreatitis, recurrent pancreatitis, early chronic pancreatitis, and acute chronic pancreatitis. According to the literature, high body fat was associated with higher readmission rate, and the sarcopenia was higher among those who had chronic pancreatitis. But the body composition parameters can be measured with bioimpedance tools, but there is a lack of investigation of these parameters in the different AP disease stages. Therefore, our aim was to compare the body composition parameters in acute pancreatitis, recurrent pancreatitis, and acute and chronic pancreatitis. Our method is a prospective data collection which takes place in the Institute of Pancreatic Diseases. Currently, we are having more than 700 cases, and we have data regarding the AP episode and details of the body composition. We are using an InBody 770 for this measurement. Our question, does the body composition of AP patients differ based on their AP disease stages? And we are investigating acute pancreatitic patients with different AP disease stages, and their outcome of interest is the different body composition parameters. According to our hypothesis, body composition is different in AP, RAP, ECP, and ACP. Just to show you some preliminary results, here you can see that a higher percentage of body fat can be experienced in the AP and RAP group, while when chronic pancreatitis is starting to develop, the patient tend to have normal or lower body fat. And we can say this from the skeletal muscle index as well. The low skeletal muscle index, which can be a measurement parameter in sarcopenia or malnutrition, so its ratio was higher among those patients who has chronic pancreatitis. As a summary, I have 3 ongoing projects, and as an additional activity, I'm also teaching dietitian student in my facility, and I had a chance to visit several international conferences with poster presentation. Thank you for your attention, and always remember Hippocrates' wise word: leave your drugs in the chemist spot if you can cure the patient with food. Thank you.
Congratulations. Any questions?
Yeah, congratulations. Amazing presentation and progress. I would like to ask about your third project. You mentioned the body composition parameters. Can they be assessed in all patients? Is there any contraindication?
Yes, thank you for the question. Unfortunately, we cannot use it for each patient because the patient have to be able to stand for like 1 minute. So unstable patient cannot be measured with it. And also there is like contraindication of use when the patient has pacemaker or stroke or heart failure disease history from the last 1 year. So in these cases, we evaluate the patient's body composition differently, but unfortunately, we cannot have this detailed assessment. Thank you.
Thank you.
Thank you. Again, thank you for your presentation. My question is about your second project, if I'm not mistaken. How did you enroll the patients, and how did you do the diagnosis part?
So the COVID registry patient,
Absolutely.
right? So when the patient has COVID-related symptoms, they visited the emergency unit and they will test it. So the COVID registry consists of suspected COVID-positive cases and positive cases. But we are going to carry out our analysis only on positive cases, and they were tested with antigen test or PCR. So not PCR and antigen test. It was like an. Yes.
Thank you very much.
Thank you.
Congratulations on your presentation. My question is regarding the third project, that the AP population there was actually heterogeneous regarding the etiologies.
Yes.
Did you find any differences or any significant differences in the body composition regarding the different etiologies present?
Yes, thank you for the question. It's really important to highlight that it's a really heterogeneous population, and there are really huge differences based on the etiology. So the biliary patients tend to have a more higher body fat ratio, and when the etiology is alcohol consumption, patients tend to have lower skeletal muscle index and lower body fat percentage.
Thank you.
Thank you.
Wonderful presentation. I want to inquire a little about fats and the background you have on that. Cholesterol is the fat in the blood that the body makes.
Yes, the
95% of it is made by the liver, and it's very hard to control it by food intake. Triglyceride, on the contrary, are the food we eat, the fat we eat. So it's a much higher probability of dietary intervention to be successful. What you haven't shown, or probably wasn't the topic, that high triglyceride levels are a real risk factor for severity once you have pancreatitis. What about cholesterol?
Whether it can influence the acute pancreatitis.
Whether it influences the severity of pancreatitis.
Well, we experience patient in our unit who has high cholesterol level, but while hypertriglyceridemia can be an etiological factor of acute pancreatitis,
that's number one.
Cholesterol level.
Where's that true in particular?
When they have higher than 11.3 millimole per liter of triglyceride level of patient.
Right, and it correlates even with higher than normal levels. So you can even 100 micromole per milliliter higher. With every step of higher, even if you don't take your cutoff, your risk of getting pancreatitis is greater. But there is a specific group that can now be treated with inherited forms of hypertriglyceridemia. You know anything about that?
I'm not quite sure that I know what you are referring to.
There's a new drug on the market, volanesorsen, which treats familial hypertriglyceridemia, which is an autosomal dominant disease, and it's very effective, and it's an RNA-based therapy. and you can reduce their incidence of pancreatitis dramatically. Anything about cholesterol and pancreatitis severity?
As far as I know, we can experience that metabolic syndrome can be a risk factor of higher recurrence of acute pancreatitis. And in this case, not just hypertriglyceridemia, but higher level of cholesterol level can be a factor. So I would say that
it's actually good for you. There's an excellent Chinese study that higher cholesterol levels mean less severity, just the opposite of
the
triglyceride.
triglyceride.
Whether that's true or not, I don't know, but you need cholesterol to stabilize your membranes, whereas triglycerides clog up your vessels, and that's probably the mechanism that does this. So you're investigating body composition by what parameters? Just waist circumference in patients or with acute pancreatitis?
In the acute pancreatitis? No. We have like more than 100 factors that we can investigate.
Okay.
Body percentage, body fat percentage, skeletal muscle index, fat-free mass index, muscle weight, also visceral adiposity tissue can be investigated.
You use CT scans and you use the psoas muscle.
We use this body composition analyzer, which is working. It's like a bioimpedance analyzer, so not CT scan.
So bioimpedance correlation between muscle and
and we would like to investigate that. Yes.
Very good. Thank you.
Thank you, and thank you for your suggestion on cholesterol and the information.
Thank you for the presentation. I would like to ask you, in the case of the second study, have you looked at comorbidities? Because, I mean, obviously, even like obesity, which is a known risk factor for COVID, can affect like triglyceride levels.
Obviously, patients and COVID-infected patient can be comorbid. We have information on diabetes and cardiovascular diseases, so we are not carried out the analysis currently, but we plan to look for the comorbidities as well to see.
Body mass index as well?
Body mass index as well. It's not, so we don't have the body mass index of each patient. Maybe we have like 20% of the data is not available, but we have an amount of body composition parameters, yes. Body mass index, yes.
And so I'm a hepatologist, that's why I'm happy that we arrived at least to a small hepatological part. So regarding your first project, have you examined the presence of other metabolic components of components of syndrome?
During the selection of the articles, we plan to exclude everything related to hepatic diseases to be able to create more homogeneous population, because it's a really heterogeneous population. Therefore, we excluded those studies which has like non-fatty hepatic status. Yes, so we have excluded
components of metabolic syndrome were excluded. Like
hypertension. We have information. So in the studies we have included are follow-up cohort studies, and the baseline characteristic table, we usually have information on comorbidities. So these kind of comorbidities, that when it wasn't like the whole reason why the study carried out, but these were just comorbidities. The hazard ratio model usually was adjusted for these kind of comorbidities, and we have used these adjusted hazard ratios. Therefore, we try to include it into our study in that way. Thank you.
Thank you for the presentation. My question is, did you exclude the inherited forms of hypertriglyceridemia from the first part of the study, which related to diabetes mellitus? And
yes, we try to exclude it, but of course we cannot say that there is a 100% sure. We are 100% sure, because we have included really huge population, and there can be a chance that there were patients with heterogeneous disease, but we try to exclude all of those studies which were related to these.
And in case of inherited forms of hypertriglyceridemia, there is a very huge amount of triglyceride in the blood. Do you know from the literature whether the ratio for diabetes mellitus is much more higher or similar to your results?
As far as I know, I have read different studies, and I find that in a Chinese studies that it was quite similar. But there was another study. It was also Asian, investigated in Asian population, and there they have found lower diabetes mellitus occurrence.
Yes, if you could go back to your first plots. Where you showed the hypertriglyceridemia and the waist circumference.
Yes.
Do you have any explanation why you... No, not this one. No, the one where you showed the... Yes, this one.
Okay.
So you mentioned that you only had statistical significance only with the normal triglyceride level with high waist circumference. Do you have any explanation? Why not when both of them are high, for example?
I do not really have an explanation for that, because these are the same studies and they were adjusted for the same parameters, same comorbidities. So the reason behind that, maybe that's elevated waist circumference, really more important risk factor.
All right, thank you.
Thank you.
Thank you.